speakers. Our next speaker is Dr. Manish Shah. He is a renowned glaucoma expert of the country. He is from Mumbai, and recently he has joined Dr. Agrawal Eye Hospital. Earlier, he used to have his own practice at Foresight Eye Center in Mumbai. Dr. Manish.
So thank you, Dr. Pradeep, and thank you to Dr. Namrata for including this session. And angle closure, both the previous speakers in the situation of normal tension as well as in the situation of high pressure, both you have to look at the patient from the angle. This thing is not moving. Slide is not moving. Slides are not moving. You have to look at the patient from the view of angle closure, because angle closure is quite common. So basically you should evaluate each patient as if it is an angle closure, and then you have to decide who needs an iridotomy and what to do after your iridotomy is done, and of course the role of cataract surgery and other treatments. So basically angle closure is, you have to keep your antennas high up and look for angle closure almost in every patient who is walking into your clinic, because it can be quite silent. And the well-described von Herrick test is useful even in a very, very busy OPD. If you look at the peripheral anterior chamber depth and compare it with the corneal wedge, then you can see if it is shallower by 1/4, then you know that it is a suspect, and you can immediately catch your gonioscopy lens and do a gonioscopy. You have to be well versed with the gonioscopic anatomy, and you do normal patients or all walk-in patients, and you can pick it up. It's very important to follow a disciplined method of gonioscopy and not just go and start looking in any direction. So you have to make the patient look straight ahead, put the room lights as dim as possible, and make the illumination height of the slit lamp as narrow as possible so that it does not constrict the pupil. And then you have to start looking from the anterior region. If you make a very thin wedge, you can identify the corneal wedge where it meets and identify the shawl base line there, and then you can see the angle and then the ciliary body band. So this is in the clinical picture. You can see the collapsing of the two parallax into the shawl base line. Then you see the curvatures of the iris, whether it is flat, it is sort of bulging in front or bulging backwards, and identify the various structures of the angle. After you have evaluated the angle for its narrowest position, you want to know if there are any abnormalities. So you want the angle to open. So you make the patient look straight ahead. You can increase the room illumination as well as the slit lamp illumination, allowing some of the light of the slit lamp to go into the pupil. The pupil will constrict and you will be able to see the peripheral angle better. And in some irises where the peripheral iris is steep, you need to maneuver the lens, either make the patient look towards the mirror, or you tilt your angle downwards away from that angle, and you will be able to identify that this is the maneuver which is called looking over the hill. So here in the first picture you can see that you are looking almost at iris plane and you can't see angle structures, and you raise your lens a little bit and you are diving into the angle, and you are able to see that it's very important at this stage not to put pressure on the eye, otherwise you will get a indentation effect and again open the angle. So this is a video which actually shows that when you are looking first along the iris plane, you can't see any angle structures. A little tilt and all the angle structures become visible, as you can see. So this is just a peripherally bulging iris, but it is not essentially a closed angle. Of course, it is an angle at risk which can close later on. Indentation gonioscopy is a very important evaluation tool, and I would suggest each and every ophthalmologist should make an effort to learn this. It's very important to look if the angles are closed, if they are synechial closure or just appositional. You use the technique of pushing the lens backwards and keep it opposed equally so that you don't get the folds, and then you will be able to see. Patient's cooperation is necessary, so you may just tell the patient you will feel a little pressure, and it has to be held continuously with gentle pressure. If it's unequal, you will get folds. And once you push the cornea a little back, it squeezes the aqueous into the angles and the iris moves backwards, and you can see. So here is a picture where you can see that nothing in the angle is visible. And when you indent, you can see some synechia, and some regions the angles are opening. This information is very useful for your long-term treatment. So the similar condition here, and you can see that the angle shows some synechia like picture. You may imagine that these are synechia, but when you do the indentation, it's actually moving back. So it is not a synechia. So indentation gives you a lot of information. In a typical synechial closure, after in an inflammatory condition, you can see these kind of synechia, and whatever you indent, it does not open. So this is a dynamic video to show you the indentation effect, and as you push, and now you can see the angle is opening, and almost all the angle structures are visible, as opposed to the resting condition where it is not. So indentation gonioscopy is a very important tool. Now, after you have done a full evaluation of the angle, you have to decide whether an iridotomy is to be done. So generally, when we see patients with appositional angle closure, our hands start itching to do the iridotomy. But you have to remember that in angle closure, there are more than mechanisms available than just a pupil block. There is the lens, there is the ciliary process, which may be anteriorly rotated like in a plateau iris, and other causes like choroidal expansion, aqueous misdirections, and such situations which we see sometimes. And in these cases, iridotomies are not really useful. So the mechanism is going to be pupil block, then iridotomy is useful. So in which patients are you going to contemplate doing an iridotomy? Acute angle closure situation, definitely you would want to do. In chronic angle closure with peripheral anterior synechia, that means that the patient gets classified as angle closure. In the international classification of closed angle and narrow angles or angle closure is angle closure suspect, whether it is just appositional closure. In the second category, you get a presence of a synechia, or you get pressure raised without any glaucoma changes on the disc. That becomes primary angle closure. And if you get changes on the disc and field, it becomes angle closure glaucoma. So iridotomies are definitely indicated in situations where you get a synechia or raised pressure, and definitely if you get glaucomatous changes on the optic disc. In the intermittent angle closure situation, where the discs look normal, many times the pressures are normal, but when you do a gonioscopy, there is 360 degrees closure, and there are typical symptoms. That patient is complaining when he goes to the theater, he sees the colored halos, and you can make an assumption or make a diagnosis that this is intermittent angle closure with headaches and eye pain, and an iridotomy is definitely helpful. In a phakic or pseudophakic, if you can identify a pupillary block because of a synechia, then an iridotomy is definitely useful. Narrow angles with signs of previous closure, where you have narrow angles but you get pigment clumps, which are very, very indicative of intermittent angle closure, an iridotomy is useful. But how to really identify whether the iridotomy is going to be helpful or not, besides looking on gonioscopy, an anterior segment OCT has been helpful. And as you can see in this patient, the one on the right side is before the iridotomy. And I'm sorry because I could not incorporate the images so well, but here the anterior chamber depth is one of the parameters which is shown up over here, anterior chamber volume, and the lens. So if you can see, the lens thickness is high in this case. It is actually already 5 micron, 5 point something millimeters. So that is quite a large lens. But you can see that contour of the iris is showing bulging. And after iridotomy, it has now the contour of the iris is very much following the contour of the lens. The bulge is gone, and the anterior chamber volume also has increased. So anterior segment OCT is very useful in identifying, as I will come to, the lens factor. Let's finish the iridotomy first. So after the iridotomy is done, what do you do? Repeat gonioscopy. And if the angles are open now, then the further treatment of glaucoma will depend on the stage of glaucoma based on the visual field. If the angles are not open because of synechia, or is it still appositional? If it is still appositional, you have the option of doing an iridoplasty, using myotics, or doing a lens extraction. If there is synechial closure, you can't do anything further except treating medically and probably opting for surgery earlier than you would in the open angle situation. Evaluation of the lens component is extremely important in angle closure. So you can see the lens thickness on ASOCT, as you can see in these images, or you can use the biometry, which all of us are having, and usually we get a lens thickness. Any lens thickness which is more than 5 or 5.5 is very significant. You can also study on ASOCT the lens vault. The lens vault is derived by drawing a line from the ciliary body of both sides and seeing how much portion of the lens is anterior to that line. The gonioscopic method of evaluating the lens bulge, this is also a very, very clear sign. If you can see, like in this picture, the whole lens iris diaphragm is caving upwards, and it is like a big hill with a volcanic crater in the center. And of course, it will be appositional closure. By indentation, you will be able to open it. But here you can assume that the lens factor is definitely playing a role. If you have access to ASOCT, you can confirm this better. Lens extraction has a role to play in angle closure, and the EAGLE study concluded that it is better outcomes with lens extraction versus iridotomy. But after this study came and was published, a lot of data was discussed, and it appeared that they have jumped to the conclusion. But in practical life, it may be better to choose lens extraction when you can see on ASOCT and gonioscopy that lens is playing a role, and already there is a cataract with an increased lens vault. Thank you so much.
Thank you, Dr. Manish, for your excellent insight into the gonioscope.